I'm very interested in how you applied this knowledge to Richard's GBM trial and any recommendations on how we may advocate for N1 trials like this for our own rare cancer.
So the question is about what do we do with these rare cancers or N of 1 type clinical trials? The first thing is that what we do need to do is approach it very scientifically. Sadly, an N of 1 trial is not enough evidence. Richard was not on a formal clinical trial. He is just a single story, and we don't know what the natural history of his tumour would be, whether he would be fine and well with standard treatment today. So we need to watch in time. But the principle is what we need to do in cancer is look at groups of similar cancers. They don't have to be the same histology. They don't all have to be bowel or breast or a rare type of sarcoma. We just need to look at the shared characteristics of these cancers and group cancers in those subgroups and then do clinical trials in those subgroups so that we're avoiding the N of 1 and we're looking at groups of similar cancers. It may not have the same name, but we're looking for signals of drug activity. What we don't want to do is cause harm. And causing harm is shortening someone's life than otherwise would have been, or really making a misery of their quality of life. So we can approach this. We can help people with rare cancers, those N of 1s. What we need to do across cancer is find the shared characteristics. That's what I did with Richard. I thought, what is it about his tumour that is shared with the worst of the worst melanoma, and take that approach. And now I'm happy to say we will be opening a clinical trial of 80 patients with glioblastoma looking at this approach that I took with Richard. Richard's story generated the hypothesis from which we now can do a clinical trial. And this can be done in rare cancers simply by looking for shared characteristics across different cancers to get a signal.
Well, that leads me to the next question, which is how confident are you that we can translate the great strides forward in melanoma treatment and outcomes to the rare cancer space?
Absolutely 100% confident. We won't cure all. We won't prolong the survival in everybody, but we will absolutely impact a proportion. And that is what the goal of sharing the data in publication form and getting a clinical trial up and running after Richard's N of 1 experience is about, is showing that we can impact other cancers. We've actually got a lot we can do with our current available treatments in cancer that we can apply to rare cancers in clinical trials by just finding similar characteristics between these rare cancers and then trialing these drugs in those. So this is absolutely achievable. It just requires a framework and a will and an ambition to get it done.
And just on prevention, there's been a lot of successful awareness work around prevention and skin checks to help catch skin cancers early. What can we learn from this about awareness and prevention for the rare and less common cancer space generally?
Prevention is a really important topic in cancer and in fact diseases in general. The first thing we've got to do is know what the causative link for that cancer is. So prevention means not getting the cancer in the first place. So to do that, you have to understand what causes the cancer. And regrettably, for a lot of rare cancers, we don't know. Many of them, we just don't know the cause. And therefore, it makes it very difficult to prevent them. But there is a lot of research trying to understand what may be some of the causative links with some of these cancers. But the fact of the matter is we may just not know what causes some of them. The other thing is secondary prevention, so early diagnosis. And although there is this idea that getting a cancer early will improve outcomes, that's not necessarily true. And in fact, in melanoma, for example, we know that our immunotherapies work. Whether it's early stage or advanced stage, we're still curing the same proportion. So if you're going for cures, technically, you should be able to cure whether it's early or late stage. And that's the thinking we need to get with cancer biology. I see a future with melanoma where we only treat melanoma when we're doing neoadjuvant in high risk early stage and advanced stage. And that's because we're curing the same proportion. So there is a perception in cancer that getting it early for all cancers is easier. And that's true for some. But if you have a really good treatment, that's not necessarily the case. So my take-home messages for prevention is, number one, we've got to find the causative links that causes specific cancers to be able to prevent them. And number two, if you're looking at early diagnosis, you have to actually do the work to work out, does early diagnosis lead to an improved outcome, improved survival? Otherwise, people are living with horrible anxiety about something they can't change, whether they discover it early or late.
And why do you think events like CanForum are important?
CanForum is really important to highlight these rare cancers, but also to create a framework to understand the big questions in rare cancers, to come together to create endpoints that enables you to group rare cancers together, to do clinical trials that don't take 20 years, that you can do them quickly, and to find pathways for people who are often left alone because there are not many people out there in the world with their sort of cancer. So I think this is a wonderful opportunity to provide a framework to make people aware of rare cancers and the issues, and just to put rare cancers on the map so that research and medical work can begin to actually make a difference. And that's what's important in cancer, making a difference.
And last question, what does a better world for rare mean to you?
A better world for rare means confidence and access to a path that gives high quality of life and improves survival.